Develop that plan. We do see the patient and we start implementing the plan. And then what you see towards the end here is that the intention, I'm sorry, the pointer is not working, but in this step 10 and 11, the intention is not necessarily for all patients to stay within the clinic, because our hope is that we will be able to stabilize, educate the patient, educate the primary care provider, link you with resources in the community, and potentially discharge from the clinic. So there will be another case conference in which the primary care physician and the person assuming responsibility would be invited to participate, and we would transfer the care with a clear plan for that. That doesn't mean the patient would not come back to the EDS clinic, but our intention is not to replace the primary care provider role, but rather to provide expert consultation for the steps that are needed. There are a number of shared resources that include a clinic coordinator, I'll read to you, then a physiotherapist, social worker, psychologist, pain management specialist, genetic counselor, geneticist, and then an admin assistant and a data analyst. Those are shared resources between the adult service and the pediatric service. And then the core of the clinic would be hosted in the pediatric side. We have recruited a pediatrician that was working in the chronic care clinic in the patients with complex conditions. And she, Sarah Schwartz, is going to be the most responsible physician there, but I will participate in it. And then in terms of an advanced practitioner, we have a nurse practitioner that has years of experience in patients with chronic disorders. In the adult side, the similar model, a medical lead. At this moment, rheumatology has taken the lead, but that is still being worked out, who the most fitting medical lead will be. And there will be an advanced practitioner. At this moment, there's an advanced physiotherapist practitioner, but we're also, again, in the pilot stage, trying to determine whether that is the best individual. The reason why a PT practitioner was chosen is because she also had years of experience assessing patients, and she has been able to do triage of patients with other genetic disorders. Therefore, we felt that it was a good use of her expertise. This completely unformatted, but this is supposed to show the stages of the clinic. The planning stage was completed in the beginning of the year. We spent all summer in active discussions. This has been a model in which we have had multiple encounters between the SICKITS team and the UHN team. The first EDS adult patient was seen in October, and the hiring process was initiated for those practitioners that I identified. The process for adopting, we also want all patient information that is crucial to be available to any of the providers by just calling the clinic. So we will have a database, and the database, as of now, we're using a program that is called Phenotypes that we're adapting for the purpose of keeping that information. We created the clinical criteria for referral, and the referral process is through a system that's called ARMS. And then the first pediatric patient was seen at the beginning of October, yes, a month ago. And we have run 3 pediatric clinics, as well as seen a few of the patients in other clinics because Dr. Schwartz has made her schedule flexible so she can occasionally go to other clinics. The idea is today we are sharing with you, and we are looking forward to working together with the patient organizations so that we can very clearly take advantage of everybody's strengths. We are aware of the strength of the ILC in terms of education, patient advocacy, and patient support, but we hope to take some of that burden in terms of the medical care and the referral process. We have also done a lot of interaction with the subspecialties that usually see the patients and are trying to develop clear referral criteria to determine which patients need to be seen by each of those subspecialties and which part of the care can be hosted at the multidisciplinary clinic. So We are now working on finalizing the case management logistics. We are developing web pages for both the adult and the pediatric side. We're implementing the phenotypes database. It's already in existence at SickKids, but not at UHN. And we are now reaching out to the external stakeholders for determining the best way to partner and to develop those education materials. So, work in progress. It's exciting. It is. We have learned a lot from Dr. Franco Mano's clinic, from Dr. Henderson's experience, and we hope that we can integrate all of this experience that exists around the world to provide optimal care and develop research projects so that we can identify ways to prevent complications and best manage complications with an evidence-based approach. Thank you very much.